versus MRI. So here we have a transverse. I don't seem to have a. Is there a functional pointer potentially? Anyways, well, so when we think of the image on the left-hand side of your screen is a sagittal proton dense image of the foot. Thank you. And when we do an ultrasound, so let's just start over here on the image on the right. So here is a ultrasound that's done through the heel bulbs, and this little area that looks like a little black eye is the medial lobe of the deep digital flexor tendon, and it has a tear in it, and that sits right at about this level. And that is more or less what we're able to ultrasound when we go through the heel bulbs. Now, you can potentially go in through the frog and look distally, but there's some limitations to that, and it depends where you live. So where I live, where it's very, very dry, it's very hard to scan through the foot, and I suspect it might be a similar challenge here. So when we think about what we can see with ultrasound, then we have to think about what else is going on in the tendon. So in this case, we do an ultrasound and we can see that we have a deep flexor tendon tear that's sitting right here. And then, but there's actually more to the story. There's more going on with that MRI. So having a few cases like this made me think that I needed to start doing a little bit more evaluating of where all deep flexor tendons go. So this horse, if we look at this image on the left-hand side of your screen, again, we have a sagittal PD view, and this horse has an insertional tear of the deep digital flexor tendon with a sort of intermediate signal down here, and then also has a tear at the level of the proximal recess of the navicular bursa. And so the blue box on the top corresponds with the blue line on the sagittal image, and we have deep flexor tendon tear here and navicular bursitis. Now, if we keep moving up the leg, so now we're here more at the level of the pastern where the yellow line is, and we look at the deep flexor tendon, it looks pretty good. So does that mean that's all of our extent of injury, or is there more? In this case, because like I said, I also like to ultrasound the horses. I suspect this is not going to play. Because I like to ultrasound the horses, I also went up into the pastern, and in the video, if it were to play, there is a core lesion in the deep digital flexor tendon in the pastern area. So what's interesting about these, if we go back and we look at this previous slide, is that a lot of these deep flexor tendon injuries will skip locations. So we'll see them in the foot, then we don't necessarily see them very well palmar to the navicular bone, then we see them above the navicular bone, and then we don't see them very well at the level of the proximal interphalangeal joint, but then they can reappear proximal to that. So that means we have to extend the range of, oh, look at that. So here's our core lesion right here in the medial lobe of the deep digital flexor tendon on this horse that had had the MRI. So the MRI didn't go high enough and didn't get the rest of this tendon injury. So cases like this and other cases made me actually want to look at what all happens in the deep flexor tendon and what is this association between the pastern injuries and the injuries in the foot. So if we look at this, so what we did is with Dr. Elizabeth Acutt, who was my former resident, we actually went back and we looked at horses and where they had lesions in the deep digital flexor tendon. And we characterized the types of tears they had. So we have a core lesion, like I just showed you on the ultrasound here in the pastern area. We have dorsal border tears, which we can see in the pastern area as well as dorsal border damage that we'll see down in the foot. We also characterized sagittal splits and changes at the proximal recess of the navicular bursa, and then just sort of a diffuse tendinosis where we have enlargement of the lobes. And we looked at all those different types of lesions, and if we had lesions in the pastern, how that corresponded to having lesions in the foot. So here is just an example of the ultrasound that we're going to do to correspond with that. So here in the yellow box, that correlates with this line up here in the mid-pastern area. And again, we have one of those core lesions within the deep digital flexor tendon in the pastern. Now, down here, we're looking in between the heel bulbs with our microconvex probe. These two black eyes are the deep digital flexor tendon. And here is a dorsal border tear in the deep digital flexor tendon. So what is the relationship between these two? And what we found out was when we looked at this, 75% of horses that had a deep flexor tendon tear in their pastern also had deep flexor tendon tearing in their foot. And to get even more detailed on that, if they had a core lesion within the deep digital flexor tendon lobe in the pastern, 38 out of 39 of those horses that we looked at had deep flexor tendon tearing in the foot. So what is the take home? How does this change how we practice? It means that if you are doing an ultrasound on a horse and you see a tear in the pastern, doing your standard pastern scan with a linear probe, you're not done. You didn't find the whole injury. And so now you either send that horse to an MRI if you can, or if not, you at least want to try to ultrasound that horse in between the heel bulbs to see what else is going on further down in the foot. So it's a really sort of important tip of the iceberg type situation. Okay, so let's move on for the sake of time to the collateral ligaments of the distal interphalangeal joint. So just to start with orientation, when we scan the collateral ligaments of the distal interphalangeal joint, we basically can see the proximal 1/3 of the ligament, and the rest of it is within the hoof capsule. So looking at the MRI on the right-hand side of the screen, that's a transverse view through the level of the middle phalanx, and those yellow arrows are pointing out the collateral ligaments. And then we have a corresponding ultrasound. And one of the big landmarks for the ultrasound is this smooth curve of bone right here, which is where the collateral ligaments sit, correspond to this smooth curve of bone right here, which is the fossa of the collateral ligament. So again, we're just seeing this proximal portion of it. And what I wanted to point out with that dotted blue line is how difficult it can be with ultrasound to really see the margins of the collateral ligament. And that's because there's the tissue sitting near it, there's a periopal, there's a lot of tissue around that area. And also it's a complex structure with fibers that run in different directions. So it makes it a challenging structure to interpret. So in one of the studies I did with the resident, we compared our ultrasound findings, again, pre-MRI and post-MRI, to see how good we were at assessing lesions. And it turned out that we didn't have a huge number of collateral ligament injuries, so we weren't able to get enough statistical strength to evaluate it. But what we did find was it's very unreliable. It is, and that would be my clinical experience too. It's very easy to over or under assess the collateral ligament with ultrasound. It's actually even a challenging MRI diagnosis. But I'm going to show you a case where we can see, and we still have more to learn. Okay, so this is a warm blood hunter who had a 3-5 right forelimb lameness. He blocks partially a little bit to PDN, but then they went up and did sort of a ring block around the pastern, and that improved it quite a bit more. And he had a palpable enlargement on the lateral aspect of the coronary band. So here's the ultrasound images. And we have medial on the left and lateral on the right. Remember, the swelling's on the lateral side. And remember, we always get oriented by this smooth, bright white line. So this curve of bone right here is the collateral fossa. So here we have the medial collateral ligament, and here we have the lateral collateral ligament. And we can outline the medial collateral ligament pretty nicely, but the lateral collateral ligament is enlarged. It has hypoechoic fiber disruption, and it has periligamentous edema and proliferation. So we kind of have put a story together, right? We have a collateral ligament injury, we have a swelling on the coronary band, we have a lame horse. So we have an answer, right? But again, sort of like the deep flexor tendon, we have a little bit of a tip of the iceberg situation. So the horse went on to get a low field standing MRI, and the image on the left-hand side of your screen with the white arrow is proximal. So that is the part that we can ultrasound and the part that corresponds to what we saw on the ultrasound. So here again, there's that fossa. Here we're at P2. But as we come down distally, the injury is actually much worse. And as we get down to the insertion where this blue arrow is, there's essentially maybe just a few little ligament fibers hanging on for dear life, and it is otherwise completely torn. So the ultrasound gave us some answer, but it didn't give us the extent and the severity of the injury. And to me then, when I scan a collateral ligament, I always, when possible, and I realize the reality of life is it's not always possible, whenever possible, I want to get an MRI, because if it looks normal on the ultrasound, it could still be abnormal in the hoof capsule. And if it looks abnormal on the ultrasound, like it did in this case, it can be much worse in the hoof capsule. So I've just flipped the ultrasound now to line up with your MRI. So again, here's the one part we can see. Here's our abnormal ultrasound. If you can't do an MRI, which you just need to let your client know, hey, yeah, we saw that this is abnormal here in the proximal part of the ligament, but it actually, distal lesions are more common, and this could be a lot worse than we recognize just from our ultrasound. Okay, so let's keep moving up the leg and talk about the sesamoidean ligaments. And one thing that I would really like to impress on you in terms of when you think about doing your past-urine ultrasound, and if you have done a complete exam or not, is, are you really getting under the ergot and getting to the base of the fetlock? Because things happen in this area, and it's a challenging spot to scan because the ergot does get in our way. And if you're scanning young thoroughbreds, it's lovely because they have thin pasterns and thin skin, and you can get beautiful images. And if you're scanning a thick warm blood who has a little bit of a dropped fetlock, it can be a bit of a nightmare. But what we want to ask ourselves, did we get, this is the image I like to see. So this is actually, so we're transverse right at the level of that blue line. This is a little line right here is a little bit of P1. And this triangle of bone right here is the palmar aspect of the sagittal ridge of the metacarpus. So I know I'm seeing right into the back of the fetlock joint, right below the sesamoids. And this is where the intersesamoidean ligament turns into the straight sesamoidean ligament. And it's a challenging spot to scan, but it is a spot where we can have issues. So this is an example of right where the intersesamoidean ligament and the straight sesamoidean ligament blend. And here on this MRI, which has been flipped to match the ultrasound, we have this area of increased signal, which is tearing of that area. And that corresponds to this hypoechoic area on the ultrasound. Interesting things about this. One is that part of the intersesamoidean ligament has fibrocartilage. So in order to tear fibrocartilage, you usually have to do something pretty dramatic to do that. And a lot of times these horses are really lame. And it can be very frustrating because can be a subtle finding and you can't quite figure out why this horse is so lame. So just the MRI really helps because it helps us see that these do exist in a really challenging area. You can see how subtle the finding is on ultrasound compared to MRI. So even if you say, you know, I think I'm going to have a hard time finding these, I still think that. I've had some that have had an MRI. I know exactly where their lesion is. And when I go to ultrasound it, I still can't see it. But it's just an important thing to know that it exists, to know this area can get this damage, and to realize that even if you don't see it with your ultrasound, it can still be there. Coming up from that, we also have the intersesamoidean ligament. So right, that was that just a little distal, right at that interface between intersesamoidean and straight. And then we can kind of, and I think we're a little bit more comfortable with the intersesamoidean ligament where it lives, where it's named, right? It lives in between the sesamoids, hence intersesamoidean. So this area, I think we're a little more comfortable with our diagnoses, especially like in this case where we have bone change. But it's a good example this horse where we have tearing of the inner sesamoidean ligament, we have abnormal signal in the sesamoid bones and correspondingly abnormal condylar signal. And so those, again, this is the MRI kind of shows us that tip of the iceberg where we can ultrasound these and we can see some of the changes, but a lot of times there's more change going on in the bone and soft tissues than we necessarily recognize without advanced imaging. This is another example. Again, we can see an obvious sesamoid fracture, but this is a good example of what happens as well to the soft tissue. So we don't want to just think about the bone, but we want to think about what's happening to the soft tissues in these cases of trauma or severe sesamoiditis to the sesamoids. And again, my clinical impression is that when horses, obviously this horse has quite a bit of bone trauma, but when horses also manage to do things that disrupt that fibrocartilage, they can be very, very painful from that. So this movie is on high speed. It's had a lot of delicious Saudi Arabian coffee, I think, and it's going quite fast. So just focus over here for a minute. This is the other area of the inner sesamoidean ligament that we tend to forget about. And it is, here's the suspensory ligament branches. So now we're above the sesamoids, but this is still intersesamoidean ligament right here. And this is a tear in the intersesamoidean ligament. So sometimes when we have suspensory ligament branch injuries, in these more severe cases, we can see concurrent tearing of the intersesamoidean ligament. And that's another area that we can ultrasound. So when you're doing your suspensory branches, it's very easy to get sort of just focused on the suspensory branches and forget about its neighbors. But the intersesamoidean ligament goes above and below the sesamoids, and it can tear above and below that area as well. Okay, so now moving on to the suspensory ligament branches. This case, this was a warm blood dressage mare. She had a chronic left forelimb lameness, and she had a known suspensory branch injury. So it had been ultrasounded a couple of times. It was a little difficult to tell exactly, it had been going on for a bit, but how much did the branch mean? She wasn't super painful on palpation of the branch. An important thing to keep in mind for suspensory ligament branches when you ultrasound them is they will continue to look abnormal once the horse is clinically normal. So once the horse is healed and back in full work, you agree persistent clinically. And she hadn't, so she had an ultrasound of the whole fetlock area, and this was the main finding. And so because of that, she went for an MRI. And here's our MRI. And let's just start on the image on the right-hand side. So we're above the sesamoid bones. Here's that intersesamoidean ligament that I just showed you in the last case. Right now we have a nice, smooth, homogeneous one sitting next to the suspensory ligament branches. And we can tell this medial suspensory branch, as we knew, is quite enlarged, has abnormal increased signal. So we were correct that there is an abnormal finding there. But what was not found on the original ultrasound is when we go down below the fetlock. So now this is P1, and we're looking at the oblique sesamoidean ligaments. Here's the straight right here. So this lateral oblique sesamoidean ligament is also quite abnormal with a lot of fiber disruption along the palmar abaxial aspect. The person who had done the ultrasound was pretty upset because she's a fairly accomplished ultrasonographer, and she wasn't really sure how she had missed this large tear in the oblique. So again, as I said, we always want to try to learn from what MRI teaches us, and whenever we can, ultrasound before and after. So we ultrasounded her again afterwards, and here are two images, one with the limb weight bearing and one with the limb non-weight bearing. So starting with the with the weight bearing, all you can see is this little touch of hypoechogenicity on the abaxial margin of the oblique sesamoidean ligament. But when you're non-weight bearing, in fact, that whole tear opens up much bigger. And so if we go back and we look at our MRI, we can see that this tear right here corresponds area right here. So the take-home message with this, and an important thing to kind of keep in mind in general when you're thinking about scanning, is that when the horse is standing, they can close down lesions just by the tension that they put on structures. And if you don't pick up their leg, you can miss abnormalities. Sure, this wasn't perfect, but that's a pretty mild finding. And if we look, there's a blood vessel right there. That blood vessel causes edge shadowing. So you can completely understand how this was not identified. And it kind of bums me out a little bit because it can be a pain to have to pick up their legs all the time. And sometimes they're not super cooperative, but it's really important to do because otherwise we'll miss lesions if we don't look at structures non-weight bearing as well. Similar type case is the suspensory branches. There are certain types of tears within the suspensory branches that are very hard to see when the horse is fully weight bearing. And this is a case that Dr. Werpy shared with me. And this one is a pretty dramatic version of it. But I've had some like similar cases as well, where when the horse is standing, they're compressing down a lesion. And then when you pick up the limb, so this horse has a sagittal split within their suspensory branch. When you pick up the limb and you take the weight off, that opens up. So here we can see the corresponding MRI, and now we have this defect in here. So again, it's just another important example of picking up the limb. And I find, sometimes I just hold the leg in my hand and that's fine. Another really helpful way to do it is if you get a farrier sling and you put the leg so that the front of the fetlock is resting in the farrier sling and the leg just kind of hangs open so that the pastern is open, but you don't want it because you don't want it flexed up because then all of your tissues get bunchy. So you just want it open and the pastern nice and open hanging from the sling. Most horses are surprisingly cooperative with doing that. And then you're not trying to hold their leg and do a bunch of other things all at the same time. So the final area I want to talk about is suspensory ligaments. This case was a young cutting horse who I had done an ultrasound on, and I did not think that his ultrasound was abnormal. So this is his ultrasound, and all I thought was that I have good fat muscle bundle definition. I can see the margins. The suspensory ligament is not enlarged. The horse went and got a MRI. And again, I flipped the MRI to match the ultrasound. So here we have a stir image where all the bone is dark or should be dark. And we have this bright area of bone. So this is abnormal fluid signal in the cannon bone at the suspensory ligament origin. And then we have a PD transverse here. And you can see that we have a lot of endosteal sclerosis. And then finally on this vibe image, you can really appreciate the amount of bone change that this horse had. So while I thought there was just a little bit here, there's actually a decent amount more than I recognized. And I actually went back to that horse and I had the MRI pulled up and I scanned the horse while looking at the MRI, trying to capture that, which is actually what this image is. And I still could never really recreate the amount of bone change on the ultrasound that we see on the MRI. But sort of more importantly is relatively normal ultrasound on a lame horse gets an MRI and significant findings. So these bone marrow lesions at the suspensory ligament origin are not found incidentally on sound horses. So those are always associated in my clinical experience with lameness. Interestingly, and my experience with this has been primarily in young Western performance horses. I haven't seen it so much in other disciplines, but they will get changes where there's in the forelimb where there's very little ligament change. The ligament can look almost completely normal, and almost all of the pathology in that proximal cannon area is associated with the bone. So the take-home point from this is even if they block there, clinically you're suspicious of that, you've ruled out any other confounding issues. It doesn't mean a normal ultrasound doesn't mean that they don't have significant pathology at the suspensory ligament origin. The other thing we need to think about when we think about suspensory ligaments is how do they get injured? So let's just start with our normal comparison image. So this is a non-weight bearing image of the hind suspensory, and it has a trapezoidal shape. And then the internal, more hyperechoic areas are your fat and muscle bundles. And they should be really well defined. You should have good definition between the fat and muscle bundles and the ligamentous tissue. And when they get abnormal, they often get enlarged. And then the other thing that happens is you lose that definition of the fat and muscle bundles. So that is a key hallmark of suspensory ligament desmopathy, is that abnormal definition between fat and muscle bundle architecture. It's not nearly as common to see discrete tears as it is to see this. So keeping in mind that definition can really help you identify pathology in this area. So this is a more extreme example in a hind limb. We'll start with our MRI in the middle. We can see that the suspensory ligament is markedly enlarged. There's a loss of the normal space between the suspensory ligament and the bone, and a marked loss of the definition of the fat and muscle bundles. And so here we have off and on angle imaging, and we can see in neither way, when we're off or on angle, do we have good fat and muscle bundle definitions. So this is a marked chronic suspensory desmopathy, and they're what I call the galaxy suspensory ligament. So if your suspensory ligament has the same tissue appearance as the Milky Way galaxy, then you can say that you do in fact have severe chronic suspensory desmopathy. The other area where we don't quite as frequently see tears, but it's something to keep on your radar, and again kind of goes back to that non-weight bearing, are these plantar lateral tears. So this is another place the suspensory ligament will tear, and it kind of just like comes out the back here on the lateral aspect. And here is this horse in weight bearing, and here is this horse in non-weight bearing. So in weight bearing, again, you can see this hypoechogenicity a little more subtle. You look at it in non-weight bearing, and that big tear opens up completely. So this is just, again, an assortment of suspensory ligament injuries or suspensory ligament angles. So when I scan the suspensory ligament, I do the majority of it non-weight bearing, and I look at it on angle and off angle from a medial approach and from a plantar approach. So here I'm coming in from the medial side, like running underneath the chestnut. Here I'm coming from straight plantar on and off angle. And what I want you to notice in this image is that even when I'm on angle coming from medial, I have this area of hypoechogenicity in the central portion of my suspensory ligament, and it doesn't completely go away, and it doesn't fill in when I'm off angle. And I see that to some degree on the plantar, but not nearly as much. And the take home point of this, and what I think is really, 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 really important, like if you get nothing else out of this talk, please take this home. This is not a core lesion. These are an incorrect diagnosis that happens all the time. Horses can get core lesions in their suspensory bodies. They very, very rarely get them in this proximal suspensory ligament. And so this hypoechoic area is just how your beam is, how it goes through the tissues, and the orientation of the tissue types in this area can make it look like a core lesion in this area. If you're not sure, if you're wondering if it's a core lesion, first of all, it's probably not, because they don't get them. Plantar, and most of the time from plantar, you can fill that in. A couple other just things to think in axis. Just remember, it's a bilobe structure, and it's not uniform across the dorsal margin. So depending on where your probe is, you might not be hitting the actual inline fibers. You might be hitting an area, a gap where there's just connective tissue in between the two bundles. You might be hitting an area of fat and muscle bundle. So for example, when you see a hypoechoic area in long axis, You cannot immediately jump to that being a lesion at the origin of the suspensory. You have to then go back, compare it to your transverse, and make sure that you're not just getting a portion in between the two bundles. So bone change is something that we see at the suspensory ligament quite a bit, and we this in transverse, and I actually find the non-weight bearing transverse to be very helpful for looking at the bone. A lot of people go to the long axis view for that, but I find that I get quite a bit out of the bone margin coming from transverse. This is just another example of a horse that has a bony abnormality. When we pick up the leg, we open up that tear. So another example of how when we pick up the fibers that might not have been that obvious when the horse was standing on. I just want to point out a few strengths of ultrasonography. So one is going to be soft tissues, looking at a dynamic exam. So we can pick up the leg and we can move the leg up and down. So in this, we're looking at the digital sheath, and we're trying to decide whether this horse has adhesions between the superficial digital flexor tendon and the tendon sheath. So this is a huge advantage of ultrasonography over MRI, is that we can't use that dynamic component. The other thing where ultrasound is really helpful is for looking as related to MRI, but it's just a little practice tip. If you're looking for fractures within the splint bone or any other surface fractures, or if it's in a more proximal area that became challenging to radiograph, ultrasound is a lovely, lovely diagnostic tool for that. You just follow down the bone. It's much easier to see bone defects at the surface with ultrasound than it is with radiographs, and sometimes than it is with MRI. And so here is an example of a splint bone fracture that we can see much better with ultrasound than we see with the radiographs. And then similarly here we have another, definitely have all this abnormal bone we can see on our MRI. But when we ultrasound this horse, we also see this mineral right here, and whether this is a small avulsion or mineral within the suspensory ligament, that's not going to show up on our ultrasound because the mineral is dark. With ultrasound, we can see it. So that gives us yet another advantage when we can put our MRI and our ultrasound together. We'll see mineral within the soft tissues that we cannot see with MRI. And so with that, I'll wrap it up and let the person go.
Thank you, Mara, for this interesting presentation. Our next speaker is Professor Lischer. He graduated from